My presentation focuses on surgical technique for compartment clearance of ITF using digital illustrations. There are multiple factors that makes the ITF clearance complex and challenging surgery. And one of the factors is inability to assess the surgical margins in third dimension because of edema. And then there can also be heavy bleeding because of tumor proximity with pterygoid venous plexus. And now we will see the anatomy of the infratemporal fossa. This illustration represents the masticator space, which includes masseter, mandible, the temporalis muscle, and the lateral and medial pterygoid muscles and pterygoid plates. The infratemporal space lies medial to the mandible that excludes the masseter muscle. This area contains various neurovascular bundles and also the pterygoid venous plexus. The oral cavity tumors, mainly the buccal mucosa and RMT tumors, have high tendency to spread into the masticator space because of their proximity with the masseter and medial pterygoid muscles, and also the posteriorly located maxillary tumors, and in some scenarios temporal bone and orbital apex tumors can also spread to this region. Where in this diagram a portion of mandible have been removed, and it shows the relationship of the maxillary artery, two heads of lateral pterygoid muscle, and how this space is bounded medially by parapharyngeal fat, and medial to that lies the internal carotid artery. So this fat makes a separation between the parapharyngeal structures and the infratemporal space. It is important to remove the entire masticator space as a single unit. This will minimize the bleeding because you are not disturbing the pterygoid venous plexus, and also by removing the compartment as a single unit you ensure that there is no residual disease left behind, especially in the third dimension. The ITF tumors can be classified into three categories: low, intermediate, and high. The low ITF involves the masseter and medial pterygoid muscles. The intermediate involves the medial pterygoid, lateral pterygoid, and the pterygoid plates. Where the high ITF tumors, they will involve the intracranial components and also the pterygomaxillary fissure area. The category 1 and category 2, these are considered operable and have got good outcomes with the procedure described. But the high ITF tumors, the tumors that have spread beyond the compartment, that is via the pterygomaxillary fissure or the foramens of skull into the middle cranial fossa. So these tumors, they are considered inoperable because when you operate them, chances of leaving behind residual disease is very high. Present demonstration is based on a posterior buccal mucosa lesion involving RMT and infiltrating the muscles of mastication, and also involving the mandible and the maxillary alveolus. So for such a case, when the lesion is located posteriorly into the buccal mucosa and skin is free, you go for a midline lip split incision. But when the lesion is located anteriorly, you need to go for a corner of mouth lip split in order to avoid necrosis of this area. The cheek flap should be raised, keeping the intraoral resection margins at least 1 centimeter away from the lesion and deep to the buccinator muscle. That is, buccinator muscles lies on the specimen site, exposing the buccal fat pad. Fascia over the masseter is taken into the flap in order to save the branches of facial nerve and keep the parotid intact. And this is how superiorly you need to expose the zygomatic bone and the maxilla. Once the cheek flap has been raised, we have to separate the masseter muscle from the zygoma and expose the zygomatic bone and sigmoid notch area. And after separating the masseter muscle, one need to release this phenomandibular ligament. After that, segmental mandibulectomy is done with 1 centimeter bony margin from the lesion. Before further mobilization of mandible, stylomandibular ligament should be freed from the mandible. After segmental mandibulectomy, the mandible is retracted anteriorly in order to expose the internal maxillary artery, and that is ligated. This is a crucial step in order to avoid heavy bleeding during further course of surgery. Please note that anterior retraction is facilitated only after releasing the spinomandibular ligament here. Once this is done, the mandible is retracted in order to expose the mylohyoid muscle medial to the mandible, and the mylohyoid muscle is separated, at the same time saving the lingual nerve along its length. Release of mylohyoid muscle enhances the retraction of the mandible, and now the palatal incision is given, followed by palatal osteotomy. And now the cut can be given on the lateral surface of the maxilla, and inferior portion of zygomatic bone and zygomatic arch can also be taken into the specimen depending on the extent of the disease. Now the specimen is down fractured and greater palatine artery is ligated. Once the specimen is down fractured, the temporalis muscle is resected from as high as possible, exposing the skull base, followed by resection of the lateral pterygoid muscle. At this point, the dissection is done by hugging the skull base bone, and this is the single most important step in this process. Once dissected, the pterygoid plates are exposed. There are two areas at this point that bleeds heavily. One is the pterygomaxillary fissure area, and second the foramen ovale. It is important to keep the systolic pressure low at this point, and also bone wax and gel foam can be appropriately used. Now the pterygoid plates are separated from as high as possible in order to remove both the pterygoid plates at once, and it is osteotomized and the whole specimen is separated. And this photograph shows complete ITF clearance with exposed skull base, the infraorbital fissure, the pterygomaxillary fissure, and root of pterygoid plates. The internal carotid artery is safe behind parapharyngeal fat and fascia.